My name is Dr. Deb Peinels, and I'm Senior Medical and Forensic Advisor for the National Association of State Mental Health Program Directors and a clinical consultant to NASDS, the National Association of Directors of Developmental Disability Services. And today my section of this is going to be talking about persons with intellectual and developmental disabilities who are in the mental health system and those with co-occurring conditions and some of the kind of big picture challenges and opportunities that we have to best serve them. I want to first point to a resource that people might find useful. There is a series of articles in Psychiatric Services that was based on a paper that was written on behalf of SAMHSA by the National Association of State Mental Health Program Directors, called The Vital Role of Specialized Approaches, Persons with IDD in the Mental Health System. I'll use the phrase IDD to refer to people with intellectual and developmental disabilities. But again, this paper was adapted and is available online with public access in two parts, one looking at clinical considerations and the other looking at policy and systems considerations. So you may want to take a look at that for more information. It's important to realize that there is a high degree of comorbidity between people with IDD and mental health needs. The prevalence rates for mental illness among persons with IDD are estimated to be 2 to 3 times higher than the general population. And one study of ASD found that by age 16, the prevalence of a comorbid psychiatric condition was 49% in 49% of the population. One of the things we know that makes it challenging to work with this population is that behaviors masked as or interpreted as mental illness become treated as mental illness across the system. So it could be that a person with IDD has a behavior that isn't related to mental illness, but it shows up when we're working in mental health services. At the same time, an individual may have a coexisting mental illness, and we have to do a really good job, and you'll hear later in the presentations about things to keep in mind as we're doing differential diagnoses and approaches to treatment. So it's critically important to understand both populations and their needs and the crossover between IDD and mental health, and to understand resources that might be available to treat them and understand even where barriers come so that we know how to remove some of those barriers. It's hard to understand all this, especially because, like me as a general psychiatrist, the required training on IDD is non-existent. So many of us have learned along the way through work with the population. Some people feel less equipped to work with the population of people who have IDD, whether it's IDD alone or co-occurring with mental illness. And so it's important, depending on your discipline, to go to, or regardless of your discipline, to go to resources where you can learn more so that you can gain some confidence in working with this population. I want to walk through 2 examples just to show you how things kind of come into play in the systems. The first one is this case I named John, and these are based on an amalgamation of cases, but largely true. A nonverbal young man in his 20s with low intellectual functioning. His father served as his guardian and was no longer able to care for him as he got older and bigger. And he was served by the Public Developmental Disability Agency. He had been in and out of foster care and group living placements related to aggression at various times when his father was no longer able to manage him. And residential providers came to a point where they felt they couldn't support him after he was continually kicking walls, furniture, and staff, and he was brought by staff to the ED. This is someone who could just as easily be brought to the crisis service at the CCBHC. In the ED, he had increased behavioral dysregulation. There was a bed wait. They identified that he needed to be hospitalized, but they couldn't find the right placement. And then there was no place to discharge him to from the community. And so he was given increased doses of antipsychotics. It was finally decided that he would be admitted to a psychiatric unit. On the psychiatric unit, he regressed. He was playing with his excrement. He was touching staff despite prompts. He had periodically was attacking staff, and the reason seemed unclear. He engaged in property destruction. And he ended up on the unit for months and months and months. And many denials to the community were coming through, partially because as he was on the unit, his behavior was worsening and it made it difficult to have anyone be willing to take him, even though it may have been later it was determined a lot of it was iatrogenic because the staff didn't know how to work with him. And ultimately they got a consultant and they built a behavioral plan around him that gave him positive goals to work for and helped him communicate in the way that he was able to communicate. In a second example, a woman, 28-year-old with autism spectrum disorder with minimal verbal skills and borderline intelligence. She was also diagnosed with schizophrenia and a seizure disorder. She was placed at home, specifically outfitted after she had been in an ICF, an intermediate care facility that was closed, and she had in-home positive behavioral treatment plans that were in place, and she had done well for about a year, but she had one period of time, and it's not exactly clear why, where her behavior became regressed again to banging her head, non-responsive to redirection. She had ABA services that were hired to help her to develop treatment plans, but those were not sufficient in the home environment. So the home environment became no longer viable. She also was brought, when her regular staff support quit and her head banging continued, she was ultimately brought to the emergency department, but there her placement was delayed and her behavioral dysregulation in the emergency department became difficult to manage. And she was held in restraints for almost 3 weeks in the emergency department. And eventually she was placed in a psychiatric hospital, and she ended up in a state psychiatric hospital, where eventually she was able to be discharged back to her own apartment and back to her own independent living through a series of steps and careful coordination. But these are both the kind of people that we might see in emergency settings, in crisis settings. They're not necessarily at the level of needing hospital level of care initially. And so it's only when things, decompensate that things get worse. As I said, she was able to be transitioned back to the community with discharge planning that was carefully constructed and hospital staff who were able to learn to work with her. So both of these individuals faced complex system interfaces between the mental health systems and the DD systems. They had complex treatment needs, and the framework for treating them involved both medications as well as looking at behavior and helping support positive behaviors. Lots of complicated ethics that went into their care, what was appropriate, what wasn't appropriate, and a lot of difficulties making sure that the workforce was properly trained. Each of those gives us an idea of where we can target improvements in the system. There's also, and which is why talks like these are important, there's also important overarching frameworks that we need to be aware of, including legal frameworks that help us ensure that people like this are receiving care in the least restrictive environments. The first leading case that I want to discuss is Olmstead versus LC, a 1999 decision by the U.S. Supreme Court that really looked at people who were stuck in a Georgia state hospital system who were ready for community-based care, but for whom discharge was not imminent. And the state was sued, and ultimately the case went up to the U.S. Supreme Court. And based on Title II of the Americans with Disabilities Act, the Supreme Court said that it was unjustified segregation of persons with disabilities, and that constituted discrimination. And this decision then required public entities to provide community-based services to persons with both psychiatric and developmental disabilities when such services are appropriate and wanted by the individual and can reasonably be offered. And lack of resources would not be an excuse to not have them. There was increasing recognition, too, that this applies to forensic patients and people in justice settings. In other words, it's very important that we're always thinking about keeping people in community settings in the least restrictive environment. Less locked, more integrated. Those are the frameworks in which we operate. And when we have cases like the first one, John, and the second one, it can be really challenging, especially when their behavior is not understood, or maybe more difficult to have the person kind of regain their autonomy and control of more positive behaviors. Other laws that are really critical to realize, we have Section 504 of the Rehabilitation Act, which offers the important right of preventing discrimination for anything where federal funding is involved. The Civil Rights of Institutionalized Persons Act, the Fair Housing Amendments Act, again, the ADA, and then in the school setting, Individuals with Disabilities Education Act, which provide for IEPs for each child that's unique to their needs. There was another U.S. Supreme Court case that's also interesting from 2017 that looked at the IDEA and requires schools to provide an education that is reasonably calculated to enable the child to make progress appropriate in light of the child's circumstances. And it sets a standard and articulated that the IDEA requires a test markedly more demanding than merely more than the de minimis test. And although that sounds very complicated legally, what that means is that when we are providing accommodations for children in school through their IEPs, is that we have to give them more than just the minimum to help them do better than just good enough. We want to make sure that if there is a child who could achieve an A, then the accommodations that we provide shouldn't be merely to help them get a B. And so I think we can think about that also when we work with adults, is that when we are working systemically, we want to think about programs and services that serve people so that they can function as well as they possibly can, not just well enough. Home and community-based services rules, which are often discussed and especially apply to waiver populations, which many of the individuals who have co-occurring conditions are under a Medicaid waiver service, which provides an augmentation to other Medicaid services, requires people to receive both health services and human services, those that support their health needs, and then other things like transportation, and other food assistance and other types of human services that help support health. And these home and community-based services must be integrated into the community and offered in the least restrictive settings possible. So we'll see more and more people with co-occurring needs living in community-based settings, like this woman I said who was able to live independently at home but had very significant autism spectrum disorder. Somebody like that would be a recipient of home and community-based services. They would be getting those supports at home. And when things are difficult, they may be coming to care to community mental health or community crisis settings. Money controls a lot of things, and we know that over the years, state budgets went into state hospitals as the primary support for people with co-occurring conditions. That has shifted significantly towards community mental health. And more importantly, although this only goes up to 2004, you can imagine the trajectory going, the lines continuing. If you see in 1986, most mental health expenditures came out of state and local government, whereas up through 2004 and beyond, Medicaid is the largest payer of mental health services. And the same is true with IDD. We have Medicaid and Medicare. Some people are dual eligible, but essentially long-term services and supports really come through the Medicaid federal-state partnership, which requires, again, thinking about things like integrated and least restrictive settings for people to receive care and the supports that they need. So what is the role of CCBHCs in all of this? Well, the CCBHCs clearly provide a key entry point in the crisis continuum. They work with preventing crises, having outreach support in clinics, then providing a crisis response that includes 24/7 mobile teams, crisis stabilization, suicide prevention, detoxification, and even coordination with law enforcement and hospitals, and then post-crisis care. And anyone who comes into a CCBHC service has the right to be assessed and screened for their needs. It may be that they need to be supported through other clinics, but essentially the CCBHC is an important gatekeeping function. And when you have individuals with co-occurring conditions, if their primary functional needs relate to their mental illness and they have a co-occurring IDD, the CCBHC is going to be an important service. And many states are combining where people are seen regardless. And so this becomes very important. The barriers at the highest of levels include siloed policies, regulatory program and financing structures, fragmentation of authorities, accountability and resources, exclusionary eligibility and coverage criteria that overlooks the prevalence of co-occurring conditions, and limited rates to pay providers, structural integration, and review protocols and reimbursement guidance that make it difficult for providers to provide the necessary supports and services. But this creates also opportunities for us to think about migrating from targeted populations in limited waivers to full population health services, like what CCBHCs require for service delivery and even the payment reforms that come with the CCBHC. Accountable care organizations, behavioral health, and long-term support services provider partnerships also have opportunities to help emerge with new service delivery structures. And we can re-examine the need and regulate markets in specialty care as new service designs are developed and as, for example, as CCBHCs, as one example, evolve. But we really need to think about these splits in bureaucratic domains and the needs, because as I showed you in the beginning with these two cases, the needs of individuals can be complex and overlap across systems. So people with co-occurring behavioral health and IDD conditions struggle to access integrated care to meet their complex needs, which is one of the reasons why this presentation set is so exciting, this webinar, helping people understand that the narrow eligibility criteria and medical necessity standards that limit access to and coverage for behavioral health care that is run usually by departments of mental health or behavioral health, and then the need for broader entitlements and to developmental services, but access is limited just to those services, even if people have mental health needs, is important to understand that these systems have been bifurcated. And the more we recognize the co-occurring conditions, the more we can advocate for individuals in need to get joint services as needed. So we're, at a high level, on a national level, on a state level, there's lots of things that are happening. Looking at how to bridge eligibility criteria across reimbursable continuum of care, having departments work together for planning and review structures. I think this is an example. This presentation is born out of that coordination to help overcome fragmentation. Treatment integration, as will be seen in CCBHCs, to address complex needs and reduce transitions in care. That's really rooted in very careful patient-centered medical home type models, or really having people who have comprehensive care in one setting with resource alignment to reimburse that comprehensive care, which is a part of the interesting aspect of the funding streams and the funding mechanisms in CCBHCs. And then looking at data to see, is this really getting us where we need to be with this complex population? There's lots more to say about this. This is just a brief overview at a high level. There are resources for training and policy development that are being developed as we speak. I urge you to look at the Link Center website, acl.gov/Link Center, which is a federally funded opportunity for anyone working in this space with populations with co-occurring conditions to lean in and look at some of the materials that are presented. There's trainings, technical assistance, and resources. It's guided by a steering committee of people with living experience with both co-occurring mental health and developmental disabilities. And I urge you to look at this as a resource, and hopefully this overview gives you some things to think about as you hear from the next presenters.
Hello and welcome. My name is Betsy Hopkins, and I am the Associate Director here at the Office of Aging and Disability Services at the Department of Health and Human Services, and I oversee programs here for individuals with intellectual developmental disability and brain injury, including our crisis programs. And today I'm just going to give you a brief overview of some of the work that we're doing here at ODES, specifically to support individuals with IDD and autism in relation to the work that we may be doing with you all in the CCBHCs. So I talked a little bit about what is ODES. We have two main areas that we support: individuals who are older and have disabilities by providing adult protective brain injury, other related conditions, and as I already mentioned, intellectual developmental disabilities. We coordinate the programs and benefits to assure that they operate consistent with our state and federal policies within the Maine Department of Health and Human Services. Specifically, people with intellectual developmental disabilities and or autism really want to be able to live as independently as they are able to. So some of the services that we provide to support that goal are home supports, community supports, work supports, career planning, assistive technology, durable medical equipment, therapy services, transportation, respite. In 2021, we contracted with the National Center for START Services to help us complete a gap analysis of and provide some recommendations to ODES related to with the goal of improving our services for individuals with IDD and autism and those who have behavioral health support needs. With that gap analysis, which is shared on our website, and the link we'll share at the end of this presentation, were some recommendations for best practices to support individuals with IDD and autism. Some of the initiatives that we put in place to address some of the gaps that were in our system included working closely with Office of Behavioral Health as they work to roll out the certified community behavioral health clinics. We had provided some training through START, crisis prevention and intervention service model training for DSPs and care coordinators and case managers. We implemented a behavioral plan work group. We have the Beckett IDD mental health multidisciplinary evaluation team, which I'll talk about a little bit later. And then we did a study of antipsychotic prescription prevalence in our system. And then I'm also going to talk about our ODES crisis program and how we work together with them. This slide here talks about how ODES envisions the access to CCBHCs and how this work might be able to dovetail well with the work at the CCBHCs. So, for example, we see the referrals coming to CCBHCs through case managers, community support providers, residential providers. There may be referrals coming from child welfare teams and or our regional ODES intake teams. They can also be referred themselves through their families, community members, community supports, etc., and all of those listed up there on the right-hand side. Some of them may be known. Some of the people who are accessing CCBHC may be known to ODES, and we would refer them through our crisis teams, for examples. And others may be new to us, and we're not aware of them, and so they might come into the CCBHCs, and CCBHC might refer them back to us, to our crisis services for supports. So some of the services under the CCBHC, of course, are listed here in the center bullet. And then for those who are already part of our ODES services while they're And while they receive CCBHCs, we will plan to provide some interval and in-person follow-up that could be identified through their case management process and their person-centered planning process, and through their through the supports they will receive through our crisis programs. So going back to the START training that we provided, the training was provided and available for free through some grant funding that we had to direct support professionals and case managers. We had 4 registration cohorts that occurred between fall of 2023 and is finishing up this spring of 2025, really with the goal of building provider expertise and capacity for serving individuals with IDD, autism, and who also have significant behavioral health support needs. The behavior plan partner work group that we mentioned was to provide recommendations for updates to our Title V, Section 19502, with the goal of developing and implementing and monitoring behavior plans and updating that process, as well as other identified concerns about our current process and proposed improvements. Some of the work group themes or crisis or some challenges or concerns that they identified included that our process right now for serving individuals through this behavior management process was overcomplicated. There were some system-wide inconsistencies. First response really for many was to correct a behavior and not ask what's happening behind the behavior of the individual in our homes and their families where they're being served. And the work group came up with a number of different ideas for improvements, including those listed here: inclusivity, some efficiencies, emphasis on positive behavioral supports rather than managing behaviors, some consistency, ways to provide consistency across our system, better communication in traditional and non-traditional methods, examine challenges that the person is experiencing and what's behind those and what are some ways that we can address those, and focusing on least restrictive interventions. So some ODES proposals, including a department bill, LD 769, which we have in front of the legislature currently, to our Chapter 5 rule. The first one is to phase out existing behavior management plans to eliminate the use of planned restraint, develop a comprehensive positive support plan process, which is underway, simplify the safety plan process. So many of our folks that we serve in our system can be supported through the use of a safety plan, but it's fairly comprehensive and complicated right now. So we put forward rule language to update that process. We'd like to ensure a clear definition between safety plan and rights violations so that we're ensuring that safety plans aren't violating people's rights. Update the regulations to include new licensing and to also coordinate with our HCBS requirements. Develop a standardized functional assessment form, which is underway. Develop a tracking system for positive support plans, which is also underway. And then require training on topics such as some prohibited practices, trauma-informed care, de-escalation processes, and self-regulation supports for individuals. Also at ODES, we have access to a Beckett IDD mental health multidisciplinary evaluation team, and you're going to hear a little bit more about that. But that includes some wraparound clinical support services for individuals, families, guardians, and service providers, support to remain in their homes, and local communities during and after crisis incidences. So in addition, we do have, we're very fortunate to have our ODES crisis services who provide services to adults who are over 18, eligible for IDD or brain injury services. And these services are available 24 hours a day, 7 days a week statewide. The crisis program administrator oversees the crisis teams. They're based out of Caribou, Bangor, Augusta, and Portland. Each team consists of a team leader, case managers, and community response workers, and the 4 statewide crisis homes are staffed 24 hours a day to provide stabilization and support through a crisis. And we see these ODES crisis services as being a key support to the CCBHCs around the state. Some of the services that they provide are prevention services. We have a separate crisis telephone services program supports mobile crisis outreach services, in-home crisis services, as well as residential services, as I've already mentioned. So when we think about prevention, we really are talking about trying to plan for the situation before it becomes a crisis. Some proactive, comprehensive, and individualized to the individual and or their team, identifying ways to help a crisis or successfully work through an emergent situation. That's what our teams are out there to do. We see this accomplished through consultation, education, and development of a crisis prevention plan. So we see some examples of prevention services, including attending team meetings, developing a crisis plan, meet and greet. We have a lot of our crisis staff who go out and proactively meet people who are maybe having some challenges in their group home or with their families. We really try to have our crisis teams build relationships before there is a crisis. Or in the case of CCBHCs, if somebody's accessing a CCBHC, they can provide that support while a person is receiving services through the CCBHCs. And they also provide a lot of post-crisis follow-up. So once they receive services in the CCBHC, we see these crisis teams as providing some post support out into the communities where they're living. As well as we have mobile crisis outreach services that are available to provide on-site assessments, consultation, education, crisis stabilization, and then, as I've already mentioned, the crisis plan development. Again, here are some other examples of mobile crisis outreach services that we have available through our system. And these are some of the things that they might do when they arrive on site. Really, they could help assist with problem solving with the agency and or the individual or their family, and whatever the case might be. Modeling of some intervention techniques for the agencies out there. They're really good at listening to the individuals and trying to get to the bottom of what the issue might be for the individual, support and stabilize in a specific situation, and then they could refer for additional supports. They also provide some unique, specialized, and enhanced services. As I've already mentioned, referrals reviewed by crisis team leaders and intended really for natural supports for non-provider settings as well. We also have access to some short-term crisis residential services that are out there. The crisis staff are present 24/7. So if a call goes into the crisis line, somebody can call back and provide some immediate phone conversation or phone services supports. Ongoing assessment of biopsychosocial needs, stabilize and help return to a person's home or assist with locating alternate or permanent home placements, and assist in crisis planning. Our crisis residential services, we have 4 DS crisis homes that are across the state. There are 2-bed homes that are available across the state. Again, these are meant to be temporary supports for individuals who, for whatever reason, aren't able to stay in their current residential setting. Some examples of when to utilize the ODES crisis teams include involvement with law enforcement. Somebody's admitted to the ER and for evaluation, and they're not able to return to their previous living situation, whether that's in a family or in a group home. Suicide attempt or serious threats. Any other dangerous situation that might be occurring for the individual. allegations of abuse, neglect, or exploitation, serious injury to a person, rights violation, assaults, and deaths. So these are all reasons why somebody might be accessing our crisis services. We also have our main crisis line, as I've mentioned. This is the number to use for when people need to contact crisis and how they go about doing that. And Lori Mitchell's email there, she's our program administrator, and she oversees this program. So thanks for joining me to hear about the crisis program and the supports that we think will be really beneficial to individuals that are accessing our CCBHCs, the CCBHCs out there. We're so grateful that we've been able to participate with OBH and with you all in developing the supports and services for individuals with IDD and autism through the CCBHCs in the communities.
Thank you for inviting me to talk to you today about the behavioral health care and psychiatric needs of people with autism spectrum disorder and intellectual and developmental disabilities. I have to confess, I've been, I think, over 35 years working in this area. I helped develop an outpatient psychiatric clinic that I oversaw. I also helped develop an inpatient psychiatric program, specialty program for people with autism, spectrum disorder, and IDD at UMass Medical School's clinical system that existed for almost 10 years and then was closed due to financial concerns. I think it was sad to see it go, and I wish we had more of them. But what I did continue to do is run a multidisciplinary outpatient consultation service. I have a contract with a few states and getting some contracts with agencies where we will help take a look at folks who are really still struggling and have psychiatric behavioral health needs. And the reason we have that team and that people want to use that service is that our patients with neurodevelopmental disorders really often they need more support. And I think I'm talking to people who understand this. They use a lot of resources. When you speak to people in the generic sort of psychiatric system, they'll say these are the patients that use the most resources in their care, and they require different forms of service. So it's difficult for us to just have them go to a generic or already set up psychiatric service that was designed for people without intellectual and developmental disabilities. So given that there's a short time for me to speak to you this morning, I am going to give you my top 10. So these are my top 10 things I've learned in all these years can be helpful when you're taking care of people with autism and IDD who have behavioral health issues. Number one, aggression and other challenging behaviors are diagnostically nonspecific manifestations of distress. I learned this early on in my career, that this is a population of people who don't have very many ways to express distress and frustration. So we see it in their behavior. And this does not come as a surprise to many people, but it's really that it's something we don't want to make the total focus of a clinical encounter, or we'll miss the chance to reduce its impact. That's because multiple factors influence the probability of occurrence at any given time of a person's challenging behaviors or their emotional distress. This is why we need multidisciplinary and whole person approaches to really meet the needs of this population. So number three, even when treatment is requested because of aggressive behaviors, the goal has to be to promote wellness. I think sometimes we forget that. We get so overly invested in stopping the aggressive acts or stopping the problematic, challenging behaviors that we forget to focus on promoting wellness. Ironically, if you can promote wellness in individuals, they're far less likely to be aggressive. In order to do that, we have to understand pathways from when a person was well to when a person is unwell. And this in our population means we have to really look at what well means in these very unique individuals for whom we are trying to provide good services. In any case, we have to understand the person's neurodevelopmental profile. So more simply put, we need to understand how this unique individual who has an atypical neurological setup in their life, how do they communicate, process information? How do they interpret their universe? And this is how we understand what is psychopathologic and what is a person with challenging issues developmentally under stress. So a tool that I feel is really helpful, and I hope that some of you have heard of this or have this, is called the Diagnostic Manual for Intellectual Disabilities, the DMID. I was involved a lot in the original DMID and the DMID2. It was a great project to be involved with. I think it's something I can highly recommend to folks as a reference guide. It's lined up with DSM-5 and ICD for all the psychiatric disorders discussed in those manuals. We would have a chapter about that, but focused on people with autism spectrum disorder and intellectual and developmental disabilities. It's a good book to have. Number 5, the chore that we have is to hunt for the things that influence the occurrence of these troubling symptoms and challenging behaviors. So I tell myself I'm going to consider when, where, with whom, and under what circumstances an aggressive or other concerning behavior is more probable. When do we see those things happening? The other thing that I do, which is really important, is try to consider when, where, with whom, and under what circumstances happiness or being calm or feeling pretty good. When is that more probable? So I'm going to work to mitigate the circumstances in which the challenging behaviors or aggression or emotional distress happens. And I'm going to try to advocate for and promote more of what is involved with somebody being calmer and happier and doing well. And those two things need to be both addressed. A lot of times we have individuals refer to us and people are taking data on how they present, but the data is all about how aggressive they are and all negative kinds of ways that they present. Take data on how people are doing well and look at when that happens as well. So we need to recognize that aggressive behaviors and other challenging behaviors and these things where we call it mood dysregulation, that this can happen in the setting of any psychiatric diagnosis. I learned this early on in my career doing some research, and we found that people who are diagnosed with psychosis might become aggressive and irritable. We found that people diagnosed with anxiety might become aggressive and irritable, that people diagnosed with depression might become aggressive and irritable, and on and on. And what we found again is that the aggression is not going to tell us what's wrong. It really only tells us that something's wrong. Those surface features. We have to dig beyond that and look at those pathways. How did the person get from being okay to not being okay? What was the road they took? How do we find out what the road is that we took? Well, we need to use a model that includes a developmental framework as well as a biopsychosocial framework. And most people are familiar with the biopsychosocial. I promote also look at things developmentally from that developmental perspective. And we want to develop what's called a case formulation. We don't want to just have a checklist psychiatry, here's the symptoms, here's the diagnosis kind of approach. We want to understand what are all the factors that lead us down one pathway to see perhaps one psychiatric diagnosis is most likely. And then we want to argue against ourselves. What else could this be? What is the most likely? One of the errors that we found in a research that we've done, we published a paper not long ago about dilemmas and differential diagnosis of psychiatric illness in people with autism and IDD. And it's at the level of symptom identification. So I have caregivers come and tell me the patient was manic, and in fact, the patient was experiencing akathisia, a drug side effect from antipsychotic medications that makes you very restless and you move around a lot. You might not sleep well. And this is sometimes misunderstood as a symptom of mania when it is not. And it's really important to make that differentiation. In any case, we ask caregivers and informants, please tell me what you saw and what you heard and when it was happening, as opposed to a label that it's received in the past. And this way we can do a much more helpful evaluation. Trauma is really ubiquitous in this population. I can't think of a person referred to our multidisciplinary team who didn't have trauma in their past. And we know from the studies of trauma on people without intellectual and developmental disabilities that it has very far-reaching effects on mood and on behavior and even on our neurological network function. So I urge people to think about what we call bottom-up and top-down impacts and interventions. So we have those parts of our nervous system that subserve like emotional content. And then we have our frontal lobes in the top-down part where we can respond to that, hopefully exercising some self-control. But in our population, there's impact at baseline for some of these things. So it's almost like with trauma, there's a double hit. So number 9, it's really important that people have meaning in their life. I'm sure I'm preaching to the choir here, but it is true sometimes a struggle to find people with IDD and autism spectrum disorder, activities, jobs, school, other things where they have a sense of purpose, a sense of meaning. And we don't always focus on strengths and what's personally motivating. We want to try to do that. We want to offer a multi-modality kind of package of services and care that's tailored to understanding this individual's unique needs. And it's difficult. It's challenging to do, but it's really important. Also, access to psychotherapy where the therapist has learned how to adjust things like CBT to help people who have learning strengths, but learning challenges as well. Number 10, my colleagues and I at UMass Medical did some research, and we looked at almost 100, I think it was almost 200 consecutive admissions. And we found that around 40% of the people with autism spectrum disorder and IDD who were admitted to a locked psychiatric unit had medical issues that, had they been attended to prior to the time that they came to my unit, they wouldn't have needed an inpatient psychiatric stay, most likely. And this is very dramatic. So many times health issues are missed entirely, but often they're recognized but undertreated. I think they're often underappreciated how much they have an impact on people's mood and behavior and mental status. The physician who worked on my team would say if we didn't get a good medical history, which we sometimes we didn't, people with autism and IDD don't reliably self-report their own medical history, and that can be a concern at times. And what she would say is we've got to round up the usual suspects. So what was the most common problem? Comorbid medical issue, constipation. Then there was acid reflux, and then things like a UTI that people missed or that was just developing or evolving, dental problems, obstructive sleep apnea, many other. I'm just listing a few here. Also, many adverse drug responses or drug side effects, which brings me to part 2 of number 10, and that is polypharmacy. So there's increasing concern about our over-reliance on psychotropic drugs to manage behavior and to manage mood, while missing side effects that sometimes cause these things to make the person look like they need more medication. And then we kind of get into this merry-go-round of chasing side effects, driving upsets, and giving more medicine that even caused the upsets in some cases. So I really ask people and advise people to really beware of searching for the magic bullet. When you make an accurate psychiatric diagnosis and you use a treatment that's known to be helpful, it can be very helpful. Medicine can be very helpful, but we don't want to see people on 3 and 4 and 5 different psychotropic medications, and we are not going to find the magic bullet. We need to recognize the need to hear what our patients tell us, and sometimes that doesn't happen. It's really important, but we also need to see what they show us in their actions. I saw people who refused their psychotropic medications, and they were wise to do this because it was making them sick. And often they would just be described as non-compliant. So we want to look past, what seems on the surface to be going on and really dig down, as I've discussed today. I provided you with a link to the NICE guidance. They're from the United Kingdom. They have this unusual thing there called National Healthcare. But it is why they have more organized looks at some of these kinds of things. The NICE guidance is very research-based and very, very helpful, easy to use. It's the National Institute of Care and Excellence. I hope it's useful to you, and I hope this lecture has been helpful. Thank you.
Hi, my name is Stacey Nonamaker. I'm the Director of Cross-System Strategies with the National Association of State Directors of Developmental Disabilities Services. NASDS supports states to provide quality, person-centered supports and services to people with disabilities. We are thrilled to support the work that Maine is doing to increase mental health access for people with intellectual and/or developmental disabilities. You have already heard from several people who have talked about this topic related to the national perspective, what Maine is doing, and practices that can be helpful to support these system initiatives. We hope that CCBHCs become another opportunity for people with IDD to receive needed mental health supports. Many of the practices to make this happen have already been discussed. It is clear that Maine has identified that there is a need for people with IDD who may also have a co-occurring mental health diagnosis to receive supports beyond those that are available in the IDD system. We are heartened to see that the Office of Aging and Disability Services, OADS, and the Office of Behavioral Health, OBH, in Maine have created functional and productive partnerships that aim to meet the needs of this population. Without that support at the top, access and effective treatment for people would not happen. As we have already covered, in order for supports to be effective, there is a need for systems to better equip clinicians, practitioners, and direct support staff with the information they need to understand and support people with co-occurring conditions. We hope that we have provided an overview and some information on some of the critical pieces of knowledge so that you can begin to really have that cross-system knowledge base in Maine. We are also heartened that through the cross-system partnerships that have been created, there is space for sharing resources like the OADS crisis team and sharing some of this knowledge. Through efforts like building systems and partnerships and building capacity to support people with co-occurring conditions, Maine is increasing access to mental health treatment for people with IDD. What we haven't covered in this video, and what I would like to take a couple of minutes to acknowledge, is that there continues to be some myths and misconceptions about supporting people with IDD and mental health conditions. I share this with you as you all keep this in mind as we see Maine as pioneers with using CCBHC as a model to support people with IDD. We need to come together across the nation to really message what we know and what we're learning about people with IDD and how best to meet their needs, especially if they have a co-occurring mental health condition. There are many myths and misconceptions that obstruct access to mental health treatment for individuals with IDD, brain injury, and other neurodevelopmental disabilities. Some of those are these folks cannot experience mental illness, that they may have experienced trauma or may experience differently because they have cognitive challenges. That these are people that cannot benefit from evidence-based mental health treatments that we use with other people who may have a mental health condition. and that these people exhibit only bad behavior as a result of their diagnosis, and it's not a symptom of mental health diagnoses or trauma that they may have experienced. In order to debunk these myths and misconceptions so that we can ensure that people get the mental health services and supports that they need, we really need to unpack the truth behind some of these statements. We learn so much in our field, and we know that people with IDD, brain injury, and other disabilities experience mental health conditions at higher rates than the general population. In fact, we know from a 2020 meta-analysis that the prevalence of co-occurring mental health for people with IDD is at or above 33% incidence. We know that there's a range that's being reported out there that's a little bit below 33% and can go all the way up to 70%. We're doing some work in the field so that we have a better idea of this prevalence and co-occurring of mental health for people with IDD. We know that approximately 75% of individuals seeking care for mental health and substance use disorders also have a history of brain injury. So people with disabilities represent about 25% of the U.S. population, and yet they're consistently reporting elevated rates of mental health concerns like depression and anxiety, and are more likely to utilize mental health services compared to their non-disabled counterparts. People with disabilities are reporting unmet mental health service needs. For example, in a nationally representative survey of U.S. adults with and without disabilities, people with disabilities were significantly less likely to receive mental health treatment or counseling when they needed it just during the past year. We also know that people with IDD, brain injury, and other disabilities have life experiences that increase the likelihood of trauma. These people are experiencing higher rates of abuse, neglect, exploitation, including victimization rates of sexual abuse. We know that these people often experience social isolation and significant bullying throughout their life. We know that these people are experiencing extensive and invasive medical procedures with or without their consent. And for some people, unfortunately, they've been separated from family, from love and support, and experiencing truly nourishing and enriching relationships. We know that people with IDD, brain injury, and other disabilities can indeed benefit from evidence-based mental health treatments, and that requires us to think about how can we adapt and modify existing treatments like cognitive behavioral therapy, dialectical behavioral therapy, motivational interviewing for people who have cognitive limitations. And we also know that while behavior supports can be very important in supporting people with disabilities, in understanding the function of behavior, in understanding why someone's showing up the way that they do. But we also know that these supports should be used alongside mental health treatments to ensure that the person is being supported holistically. There is a crucial need for mental health providers to practice good clinical skills that they already have, trusting people with disabilities as experts in their own lived experiences, and being willing to explore disability through open and ongoing conversation instead of relying on the assumptions that what we're doing in the mental health system will not benefit people with intellectual and/or developmental disabilities. So we thank you for taking time out of your busy schedules to watch this video. We appreciate the work you are doing in Maine to support people with IDD and co-occurring mental health conditions.